Welcome.
Thank you. All right, everyone. I'm Dr. Tallavajhala, but I have my patients call me Dr. Sonny. It's nice to meet you all. Today, we're going to be talking about how to help prevent complications in Parkinson's disease, focusing in on speech, swallow, and fall prevention. So, kind of going over what we'll be talking about. So, a little bit of background on Parkinson's disease itself, and then each of those different sub-elements I had talked about. Some disclosures, I myself am a movement disorders neurologist. I respect the role of the allied healthcare professional, so my physical therapist colleagues, occupational therapists, speech language pathologists, and just recognize that I am not those professions, and so I rely heavily on their support, especially when talking about things like speech, falls, gait. Those kind of things are very important and supplemented by these different roles. So just keep that in mind, okay? We do have some empty chairs around the room too, as well.
Let me scoot over.
Yeah, we can bring everyone to have a seat. So let's talk about Parkinson's disease. Okay, so Parkinson's disease characterized by degeneration of neurons in the brain, leading to motor and non-motor symptoms. Parkinson's disease in 1817 was first described by James Parkinson. He had his essay on the shaking palsy. And from that point on, it was known as Parkinson's disease. In terms of Parkinson's disease, it's the second most common neurodegenerative disease after Alzheimer's. Affects about 0.3% of the population and 1% of the population above age 60. That's a solid number of patients. It tends to affect men more than women, about 3 to 2, and the mean age of onset is usually sometime between 60 to 70 years old. So in addition to that dopamine loss, the core feature is loss of the neurons that produce dopamine. That's in the substantia nigra. As you can kind of see in this picture here, in a normal healthy substantia nigra, you have this black band, which is where the dopamine neurons are contained. In Parkinson's disease, we have diminished substantia nigra. And that's due to the Lewy body, the Lewy pathology. It's an aggregation of alpha-synuclein, which contributes to that neurodegeneration. We'll kind of touch on this a little bit more when we look at some other things. Predominantly, in terms of the symptoms that we're going to be talking about, common symptoms of Parkinson's disease are going to be tremors, rigidity, bradykinesia, the slowness of movement, and postural instability. But that's just the tip of the iceberg. In terms of disease progression, each patient is very individualized in terms of how the symptoms affect them and how it's going to progress over time. What I like to say is once you've met one patient with Parkinson's disease, you have met one patient with Parkinson's disease. So you have to treat each person individually, and that's the importance of having personalized care models to your individual patient so that you can manage each individual person effectively. So as you can see, there's a lot that goes on underneath the iceberg too for Parkinson's patients. In terms of progression and staging, a question I get a lot is, what stage of Parkinson's disease am I in? What will my progression look like? Unfortunately, staging scales in Parkinson's disease are more useful as snapshots in time for research to know how severe one patient looks compared to another patient, but it doesn't really tell us how the patient's going to progress over time. It's more of a communication between providers about where someone is. In terms of staging, say a patient is taking medications, they can jump back and forth between separate stages just based on how well their symptoms are treated. So it can be a hard gauge to really pin down. Something I like to look at a little bit more is this image from Lancet Neurology. It talks a little bit about the clinical progression and the symptoms in Parkinson's disease, about when you should expect those kind of things to pop up, and then also how disabling those symptoms are, hence the amount of the graph they take up on here. It defines time point 0, this initial 0 period for the first time someone starts to have motor symptoms. So that can be things like the tremor, the changes in their walking, swinging arm less, those kind of things. Prior to that, in the 20 years before, you can get some of those prodromal features, the constipation, the acting out dreams and sleep, REM sleep behavior disorder, decreased sense of smell, all of that can be some of the things that pop up beforehand. after you have the onset of motor symptoms, as the disease progresses 10, 20, 25 years along the line, you can then start to get into additional symptoms, some complications from the disease. Things that we're going to be focusing on today are things like dysphagia, which is a fancy word for trouble swallowing, postural instability, freezing of gait, falls, kind of in this time frame where we start to see these things pop up. But that doesn't mean that the risk of falls or the risk of speech difficulties don't have some role in the earlier stages. So we'll be talking about early recognition to help prevent these complications. Everyone with me so far?
What's MCI?
MCI is mild cognitive impairment. You score poorly on tests, but you're able to take care of everything yourself. So not yet at the stage of dementia. And just like that, if there are questions that pop up, feel free to chime in with questions, and then we can talk about them as we go. So let's talk a bit about the motor control pathways. So back to that essay on Parkinson's, the essay on shaking palsy that Parkinson first described. His first sentence in the paper is very interesting. It says, it's a disease characterized by involuntary tremulous motion with lessened voluntary muscular power, in parts not in action and even supported, and there's a propensity to bend the trunk forwards and ask for walking or running pace. Those were the first things he noticed in Parkinson's patients. The thing that I want to bring your attention to is he used words like voluntary, parts not in action, times where you're not thinking about the movement, when some of the difficulties come up more. Propensity, meaning an automatic position, this position that the body is starting to hold, something that you're not necessarily thinking about. Now, why is that important? So when we look at the brain circuits that control voluntary movement versus automatic movements, we know there's some different pathways involved. So if I want to lift my arm up, make this dedicated movement to make this bicep here, it's going to go through this pathway. It's called the pyramidal pathway. That's a fancy word just because these pathways run through this medullary pyramid. This is not what's affected in Parkinson's disease. This pathway is not related to dopamine production. So when we intend to move, when we're learning how to move, learning new movements, this system is in control. Now, the more automatic movements are part of the extrapyramidal. So this pathway is, as you can see, a bit different. It doesn't go through those pyramids like before. This is the basal ganglia pathway, but it is the one that is driven by dopamine. The reason why that dopamine deficit starts to impact patients with Parkinson's disease. As I showed you here, here's that loss of the neurons, the substantia nigra neurons, and you can see the pathway really starts here, where dopamine then starts to go and have this control on this whole pathway. So now automatic processes. What are we talking about with automatic processes? Kind of some easy things to think about are blinking, swallowing, swinging your arms, those kind of things. Things you don't necessarily think about, but it's things that you do every day. But you can control those movements. If I say blink more, you can start to think about it and blink some more. If I say swallow, everyone here can actually take and swallow when they need to. If I say swing your arms more, you can think about swinging that arm more. So the automatic movements modulate the voluntary movements, but Parkinson's disease affects this extrapyramidal pathway. So I'll come back to this a little bit more when we're talking about how to help with some fall prevention, some speech swallowing strategies. And this is just to show you kind of side by side. On the right is that voluntary pathway, and on the left here is that automatic pathway. So let's talk about monitoring speech and swallowing changes to start. So as Parkinson's progresses, individuals can experience changes in their speech and swallowing. It's important that we regularly monitor these so that we can prevent complications. What types of speech difficulties come up in Parkinson's disease? So Parkinson's patients may experience difficulties like slurred speech, reduced voice volume, monotone delivery of their speech. It's important to detect these things early and intervene early so that we can help with communication and preventing complications. About 90% of patients with Parkinson's disease develop some kind of speech difficulty. And then amongst patients who do have speech difficulty, aspiration pneumonia due to swallowing issues accounts for about 70% of the mortality rate in Parkinson's. So when patients ask me, will I pass away from Parkinson's disease, I tend to talk to them about it's something that patients tend to pass away with Parkinson's disease. But one of the things that I want to help prevent for patients is trying to identify is there some kind of early swallowing difficulty, because such a large proportion of patients can pass away from things like aspiration pneumonia. So what kind of interventions do we have? We're going to talk about some of those things, but speech therapy is going to be kind of the crux of the assistance there. So let's talk about what kind of changes happen in Parkinson's patients. So as you all know, there's bradykinesia, rigidity as part of Parkinson's. That's going to be the muscles are going to be slower in how they move with attention, then stiffer as they try to move. Some of you might be on medication that are helping those kind of symptoms. Your vocal cords are very tiny muscles as well. And those muscles can get stiff and rigid and slow. As they start to slow down, there's some compensation that starts to occur. So normally, your vocal cords have this kind of thin, narrow closure, allows for them to vibrate very quickly and then make these high-pitched sounds and quick sounds that you're wanting to make. Over time, as you have that stiffness, tightness, rigidity in those muscles, you can get this bowing of that vocal cord closure. And so that has two problems. One, it's a slight opening to the lungs. Second, it doesn't allow efficient vibration so that the voice quality becomes quieter, more breathy. Those kind of things start to occur as well. There's another thing that I don't have pictured here, but part of Parkinson's is the epiglottis that helps close off this whole pulmonary circuit from the esophagus. That closure tends to slow down, which also contributes to aspiration. So with swallowing, there's 3 stages of swallowing. You have your oral phase where you're chewing on food, and then you push the food and liquid back to the back of the mouth. And you have the pharyngeal phase here in the middle where food, water bolus is now going to be crossing over that vocal closure. And then you have the esophageal phase where it starts to get down to the esophagus to transmit food, water, things like that to the stomach. In terms of what we're looking at in Parkinson's patients, this epiglottis closure also slows down. So it was pretty small there. I don't know if you can see it, but my little animation here has it so that you can see it's not closing down as far as it needs to close off that airway. So your food particles, water particles, things like that can start to slip and go down the wrong tube, if you will. So back here is the esophagus where things should be going. In front is your trachea leading to the lungs. And so that kind of sets up an environment for bacterial growth here on the trachea side of things, which is where we get into aspiration pneumonia. Things that can also occur here is because there's that slowing down, weakening, sometimes there can be an impaired cough reflex. We don't cough as well as we should with Parkinson's.
Choking a major issue.
Yeah, so choking is an issue that comes up as part of that dysphagia. So dysphagia is trouble swallowing is choking. And we're trying to get ahead of that with some of the interventions we're talking about today. So, good transition point is what sort of interventions do we have for these speech and swallowing problems? So important to identify these to help improve quality of life. And then also some of these interventions can be speech therapy, dietary modifications, and some assistive devices. So we'll talk about different options. So with speech therapy and exercises, like I said, a lot of these structures are muscles. And so with muscles, working out the muscles are things that you can do to strengthen them in very decisive ways. So you have to focus on strengthening these muscles to actually have benefit. Passive use of these muscles and just unconscious thoughts about them don't necessarily help improve the movements. So like I said, the problem with Parkinson's is that automatic functions that become more difficult, whereas the voluntary pathways are still intact. So you're able to control these things to some extent by using focused exercise strategies. So speech therapy, what are they able to do to help out with the swallowing and speech dysfunction? One is they can look at your speech mechanics, look at how you talk, evaluate what is the problem with what's happening with your speech. They can help you out with language functions too, if there's sometimes difficulty with word finding or identifying the right word or confusing words together. They have strategies to help with that. But their name is actually unfortunate to just be called speech therapists because they do so much more than just the speech. They can help with cognitive rehabilitation too. So if there's some problems with trouble thinking, memory, they have strategies to help with that. And then they also help out a lot with the swallowing mechanics as well. So speech therapists are very useful when we're talking about some of these swallowing risk factors. Now, I'm not a speech therapist, but in terms of what I've seen with discussions with speech therapy, is one of the most important things are vocal hygiene. We'll talk a bit about that. And then other types of interventions, respiratory swallow training. That's this idea where when you're swallowing, you should be exhaling just a little bit, something that happens on its own to help keep food from going down the wrong pipe. So there's some training techniques that speech therapists have to work on that aspect. There are dysphagia-focused therapies that speech therapists have that have certain programs to focus on just swallowing itself. And then there's some other focused programs you guys might have heard of. LSVT, Lee Silverman voice therapy, loud being the voice aspect of it, are things that can help out a targeted program. And then Speak Out is another therapy developed by the Parkinson's Voice Project as well. So in terms of the strategies I was talking about, let's start with vocal hygiene. So for vocal hygiene, it's going to be very important to stay hydrated. Like I talked about, those are very thin muscles, very fine muscles. They get dehydrated really quickly. So if you're dehydrated, those muscles are going to dehydrate well. I'm going to hydrate here real quick. But it's not just you swallowing the water and getting the water onto those vocal cords, because if it's working properly, you're actually covering everything up so the water goes down the right pipe. So what you're doing is you're increasing the amount of fluid intake that you're having so that the fluid intake in your cellular distribution is increased so that those cells are able to get better hydration, and so they can function a little bit better. So lots of water, stay hydrated. Other things are don't dehydrate yourself. So ways that you might dehydrate yourself are things like alcohol, caffeine, teas, coffee, things like that. So if you are having things that dehydrate you as diuretics, make sure you're taking in enough water to make up the difference. You also want to avoid things that would irritate the vocal cords, irritate that kind of region. So smoke inhalation, so definitely smoking is a big risk factor for exacerbating the difficulties that the parents can have. Secondhand smoke can also contribute to this as well. So definitely trying to get away from smoke exposure is very important. Reflux is another thing that can contribute to some irritation of those vocal cords as well. So if you've got stomach acid coming up from the stomach up the esophagus, the next place on that path is the pharynx, and so your vocal cords are right there too. And if there's difficulty with complete closure of that glottis like we talked about, some of that acid can get up there. So making sure to talk with your doctors about having good control over reflux can also help out with keeping the voice in a good state. And then lastly, avoiding strain and trauma to those vocal cords as well. So anyone who's maybe gone to like a football game, basketball game, or a concert, yelled at the top of your voice, cheered for your team, things like that. Voice doesn't feel so good after you're done doing that. So when you're actually talking or speaking up, making sure that you are speaking without straining your voice. So those are kinds of things that speech therapists do a good job of helping you practice how to speak without causing more damage to those vocal cords. In terms of respiratory muscle strength training, these are interventions that were created to help patients who have pulmonary problems like COPD, asthma, things like that, with devices to help with taking in larger breaths of air. They've developed certain types of techniques, EMST and IMST, which are expiratory muscle strength training and inspiratory muscle strength training, to basically help the abdominal muscles, the diaphragm, and the intercostal muscles to help with expansion. Some research has been done that shows that the muscles in the vocal folds, as well as the pharynx and larynx and the soft palate, all of these muscles, by using some of these respiratory muscle strength training devices, can actually strengthen by using this too. Also helps with that breath support as well, to be able to actually enunciate, project, be able to speak with intent. So can't really speak loudly if you don't have the breath support to support that. So has a lot of good supportive features for helping with the speech techniques. And then, like I said, intentional movements, voluntary movements, things that you can control to help the automatic movements work better. So things like smaller bites, frequent chewing, making sure you're being very dedicated with that so that you have the best opportunity to swallow what you're meaning to swallow. Something I tell my patients while they're waiting to get in to see a speech therapist, tuck your chin when you're swallowing. Some people think tossing the head back to swallow helps it go down, but that actually just opens up the pathway further for food, water, things like that to go down the wrong pipe. So tucking the chin can help you out there. And like I mentioned, there's some interventions that are done through Lee Silverman voice therapy, loud and speak out therapies. These are two types of speech therapy that are provided by speech therapists at University of Colorado. And these are things that can also be done virtually as well. So not necessarily things you have to do in person with a speech therapist. Might be beneficial to have one session in person, but then these are pretty regimented programs, 3 to 5 times a week for 4 weeks or something like that. And then additional types of things. You could also modify the diet to help managing swallowing difficulties, take in softer foods, thickened liquids, smaller, more frequent meals. All of these kind of things can help reduce the risk of choking and aspiration. So, and then, so say we're getting past just some of the more simple methods for preventing some of those swallowing difficulties or speaking difficulties, and we are getting into the point where we need some help. So for assistive devices, there are various types of enhanced communication devices. Speech amplifying devices can help out with speaking up if you're having trouble with being able to do the exercises further or have kind of reach the end of your limits of what you're able to do there. Sometimes patients, when they're in a really bad shape, they have a lot of difficulty getting any words out. So being able to communicate what you want to say, or at least communicate your intent, is important. So sometimes simple things like sign language, yes, no, absolutely not. Things like that can help your care partner know what you mean when you're in a really rough time. Written word, so writing with pen and paper or using those cell phones to text your message across. If you're having a lot of speaking difficulties at a certain time, can also be very helpful. The big point is we want to make sure that you're communicating independently and making your needs known. So in terms of nutritional intake, so if you are having swallowing difficulties, in Parkinson's disease, there are times where things get a lot worse when we are sick, ill, maybe we've got a virus going around or we've got some sort of stomach bug, then all of our Parkinson's disease symptoms get a whole lot worse during those times. And it can sometimes take a little while to get through that. Say we're hospitalized for a surgery and it takes just a little bit longer for us to recover from the surgery. Temporary nutritional aids are helpful. So sometimes things like feeding tube, egg tube, NG tube, things like that are sometimes temporary options to help with getting that nutrition we need, so we can get strong enough to be able to get better and get back closer to where we were at before. And then you can look at things like dysphagia cookbooks, different types of meal replacement options that are present to help you with being able to avoid swallowing things that are more difficult. Okay, so that's just a little bit of a page out of speech therapy and occupational therapy kind of handbooks, but that's pretty much everything I have on speech-related problems and preventing speech-related complications and swallowing complications. Before I go forward to the fall step, any questions about speech? Yeah.
So who would you recommend that be first evaluated? Okay, know you have the disease, but you're not having trouble. Is it good to get environment or is it?
Yeah. I think it's very important for patients to definitely touch base with a speech therapist initially, even when they're first diagnosed, and then just get some of these interventions and things that I have kind of briefly touched on available to them. And then you don't necessarily need to be seeing them consistently, but then as things pop up, maybe 2 years later, 3 years later, touching back in with the speech therapist. My screening question for patients to know, hey, do I definitely need a speech therapist on board? Is, are you coughing with pills, liquid, solids? So it's not over choking on these things, but it's just maybe a subtle sign that maybe we're having a little bit of a problem. And that's enough for me to open up the door and say, hey, let's talk with speech therapy about some of these swallowing strategies. Because that's the big one we don't want to miss, that aspiration risk. Because once we don't want to find out about it when someone has pneumonia and they're in the hospital. We want to find out about it when they're diagnosed and talking to us. Good question. Okay. So, mitigating fall risk through fall prevention. So obviously to prevent fall, no more pumpkin spice lattes. Just kidding. So why is fall risk important? So falls are the leading cause of injury in patients who are above the age of 65. About 1 in 4 adults above the age of 60 actually report falling each year. The CDC has been tracking falls since 2015, and the data has shown that there has been an increasing number of unanticipated fatalities related to falls. And that is increasing over time, albeit we do have an increasing aging population, so maybe we're just capturing more because more people are getting older. But still, it's a very important thing to catch and prevent, which is why we're talking about it today. Other things about the importance of fall risk is that it helps contribute to your guys' independence, maintaining independence as long as we can, maintaining your quality of life. And then also there's a component of care partner burden. If you keep falling, there's a lot of anxiety on your care partner. Oh my gosh, is he gonna fall today? What if he falls and I can't help him get back up? What are we gonna do? So, or what if he falls and he gets a hip fracture? You have to take care of him in bed at home. All of these things are conversations I've had with patients and their care partners, and it's as big of a problem for the care partner as it is for the patient as well. So recognizing that is important. So what kind of factors contribute to fall risk in Parkinson's patients specifically? So there is the inherent symptoms of the disease, which are balance difficulties, muscle rigidity, medication side effects. Identifying those kind of things are helpful. With balance issues, Parkinson's patients tend to develop balance issues at some point in the disease course. And it's one of the things that does not necessarily respond as well to the medications that we use. Muscle rigidity, when a patient is off medications, can slow down their movements, make them really stiff, so that they're not coordinating the movement as well, not moving as quickly, so that can contribute to a higher fall risk as well. Medication side effects can cause maybe some dizziness, instability, dehydration. These kind of things can also contribute to fall risk in people with Parkinson's too. So let's talk about how do we individualize some of this fall risk assessment. So big thing is getting that detailed patient history. That's where this starts. To really identify the underlying causes, your doctors need a really good story about what happens with falls. So whenever a patient tells me, hey, I've had falls, hey, I'm falling, I ask the patient, give me some examples of your fall. Tell me about what happened with the last fall that you had. Tell the story of what happens and maybe keep a diary of those, because that's going to help your doctor out. We'll talk a bit about some helpful details that you guys can think about if you start experiencing some of this. In terms of figuring out fall risk assessments, looking at the medications that you're on, or looking at the mobility that you have, working with your doctor and physical therapist about mobility limitations can help with identifying fall risk factors. And then environment and sensory assessment. So looking at the space you're living in, looking at your home environment, looking at whether there are changes in your perception or cognition that are subtly affecting your propensity to fall. These are all things to look into. So what can you do? So these are details that you should think about. How new is the symptom? So think of the timeline when it's occurring. Is there a particular time of day it's occurring? Is there a pattern to it? Is there a frequency? How often is it occurring? Is it occurring multiple times a day? Is it occurring once a week? Is it only occurring in the evening? Trying to identify these factors can help us determine what are the causes. Is there something that we can reverse or kind of change to help decrease the risk of falls? Or is this a more permanent issue that's related to disease progression? So we need to work on activity and environment modification to help you. Tell us how it's impacting your daily life so we can help you determine what kind of strategies we can get around. Here's a very large table that none of you should memorize. Your doctors don't even have all of this memorized, but it's a list of factors that contribute to fall risk in Parkinson's patients and also the general population. You can see this column over here are just generic age-related factors that are very common risk factors for falls. Over here, you've got specific Parkinson's-related factors, and here we have some other factors associated with it. I'm not going to read this list stuff for you, but we'll go back to this list. It'll pop up a couple of times in the presentation. Here's a fall risk, or a fall diary, I should say, for tracking your symptoms. So each of these columns are kind of individual dates that maybe if you have a fall, you can keep track of these events. So tracking down what time of day the fall happened. Did this occur sometime after medication? So put down, was this 30 minutes after I took medication? Or was this 4.5 hours after medication, 30 minutes prior to my next one? Am I on or off during this time? And then where were you when you fell? Were you in the bathroom when you fell? Were you on your way to the bathroom, in the hallway? Were you out in the street? Were you going on a walk? Were you walking your dog? Doing all of these kind of things. Were you going upstairs, downstairs, going over a curb, going through a doorway, trying to kind of pick out the pattern of what were you trying to do when you fell? What was the last thing you were doing just before that time? Which direction did you fall? Typically, falls in Parkinson's disease tend to be falling forward, though you can get some falls in direction. Falls that are a bit more concerning are ones where you're falling backwards. So we have a lot more difficulty with being able to control that kind of fall. And so we really need to work on figuring out what's going on if you're falling backwards. And then what injuries did you sustain? Did you hit your head? Did you bruise something? Did you lose consciousness? Those kind of things help with triaging how severe these falls are. And then what do you think caused the fall? So as a patient, you have a really good perspective on your symptoms. And sometimes what you think is going on is definitely very valuable. And we can maybe understand what your perception of the fall is and help you understand what's going on when you are actually falling. Sometimes there's a discrepancy. Sometimes you think, oh, I just fell because I tripped. But really, we fell because we're freezing and we're in an off state during that time. But we're only going to know that if we can really put a pattern to it. And then how did you get out off the floor? How did you recover from the fall? What was it that you did to get back up from the ground? And then what did your care partner or family view when you fell? Maybe you lost consciousness before you fell down. Maybe you had some other movements occur when you were falling. So some things that you might not be seeing that others see can help us with determining. So, and sometimes care partners, family, friends, they can't be at all the doctor's visits. So having their notes down in your fall diary can help out. So I'm going to go over some kind of patient stories about some common symptoms of what occurred, just to maybe give you some ideas. But ultimately, it's going to be important that we kind of use this as an outline for how to shape your description of your symptoms so that when you talk to your doctor, they're able to help you in figuring out what's going on. So in the first case, I had a patient who said, I fell in the street, felt like my feet got stuck to the ground, seemed like I couldn't walk, but I insisted, and instead of stopping, I insisted and fell forward. So in this patient, a little bit more background. She recognized that this happened on an afternoon walk. Normally, she takes her walks in the morning a couple hours after she took her medications. But that day, she had her family over. So she needed to change her day routine. So instead of going on her walk in the morning, she went on the walk in the afternoon after kind of a large meal. And we kind of found out that, hey, this was an outlier. What were you doing in the afternoon? We determined that large meal was the time that she took her medication. Usually she takes some smaller meals. And so it impaired the absorption of her medication. And so that allowed us to then make adjustments so that she was absorbing her medication more. So that's what, as a doctor, I was able to work on with the patient. But there were some additional things that we could talk about too. The activity that she was doing, she did a really good job of having that exercise in the morning time during the time when she was in an on state. So we could then track together, are there other times where you're noticing this type of wearing off, feet sticking to the ground? So she could keep a diary of those symptoms so we could maybe further fine tune things. Other things could be that with talking with like a physical therapist, mentioning, hey, when I go out on walks, that's when I'm more likely to fall. So maybe we take trekking poles with us out when we walk, more points of contact on the ground. Or maybe we need to be using a walker or have some kind of strategies to help us when we're out and about instead of at home. So kind of a multidisciplinary approach to helping out with those symptoms. Here's another patient. He had said, I found myself feeling more out of balance in the evening. I tend to fall when I'm on the way to the bathroom. This doesn't feel like a medication problem. I don't feel like I'm on. So he was able to recognize that the times he was falling, he felt pretty well treated. He did not have his tremor. He didn't have much rigidity. He was feeling pretty good, but he still felt off balance, like he was going to fall, typically in the evenings. When I hear this story, it makes me think about something in particular, especially since he felt well treated, but at the time of the clinic visit and when he's walking around, he's using a walker when he's out and about. So it made us think, hey, what's going on? Why do you still need to use this walker despite feeling pretty good? So there's certain sensory systems that help with maintaining balance that are not exactly Parkinson's related. And this type of problem comes up a lot in the older population. Your vision, your vestibular function, that's the inner ear, and your proprioceptive function, that's kind of spinal cord neuropathy regions. That 2 out of 3 of these systems have to always be turned on at all times to make sure our trunk is in the right position, that we're maintaining balance. If you take away one of these 3, you can still function. If you take away 2 of these 3, you're going to be more likely to fall. So an example for you guys to kind of look at, if you have all 3, you're going to be doing well. If you have take away vision and then you are still able to see, you're just going to rely on vestibular function. If you take away the ability to sense where you are in space, that neuropathy component, you'll be okay. But if you are only relying on one of those things, so if you blindfold a person who has neuropathy, they're only relying on their inner ear to stay upright, and they're going to fall in. And so that's what was happening in this patient. We found out that at nighttime in the evenings, he wasn't seeing as well. He didn't have a very lit corridor where he was walking to the bathroom. We determined that he had some peripheral neuropathy on exam. He had a vitamin B12 deficiency. B12 deficiency tends to come up a lot in Parkinson's disease as well. There is some data to show that levodopa actually affects the metabolism of B12 as well. So being on B12 supplementation is safe and helpful for patients who are on levodopa. But what we did was we treated his B12 deficiency to prevent any further worsening of his neuropathy. And then we implemented hallway night lights to help prevent further falls, and at 6 months, he wasn't falling anymore. And so that balance and unsteadiness, we were able to kind of find another thing going on that was not just the Parkinson's disease. So remembering that as we age, we can have all the things that affect us as we age also occur in the context of Parkinson's disease as well. So, like I talked about, to help with preventing falls, determining the cause of the falls, what is the story? That story is so important for your doctors to figure out what's going on. Keep a diary of the symptoms if it's hard to remember that story. Preventing it, what can we do to help reduce falls? So we can either affect the person, so we can adjust medications, we can educate the person, we can do more exercise, focusing on balance, strength training, things like that. Those are things that can help reduce individual fall risk factors. We can modify activities, so adding a walking aid during that risky situation where we're likely to fall. Maybe adding the walker to the hallway where we're likely to fall, having a walker in the hallway and a walker for going out and about can be helpful. Sometimes if you're getting up at night to go urinate, that's when you're likely to fall, adding things like a bedside pillow, bedside urinal, things like that that help make that activity easier so that you're not likely to fall on your way there. Adjusting things about your environment. So adding things like night lights like we did in that other case, or grab bars, or maybe just getting a formal complete home assessment. So that's something occupational therapists can do where they can come out to your home, assess kind of different nooks and crannies where you might find yourself getting into trouble. And then rescue. What should we do when a fall happens? So things like life alert bracelets, Apple Watches now having things like fall detection alert to family members, strategies for how to get back up in case we fall. So strengthening ourselves so we're able to do that push up to get ourselves back up, working with our physical therapist to say, hey, if I were to fall, can you help me with some strategies on how to get back up? All of those kind of things are very helpful with the fall prevention aspect of things. And then in turn, oh yes, go ahead.
Here's almost fall. I mean, how does that fit in? I tip a lot. I catch myself, but I tip a lot.
Yeah. That's
Where does that fit in with, I don't actually fall down a lot, but.
Yeah. Yeah, and this patient here, he was finding himself falling in the evenings, but in general, he just felt off balance during the daytime. He wasn't falling during the daytime. And so that definitely fits in with getting an evaluation for what it is that is maybe causing that balance to be just a little bit off. It's definitely similar to the speech difficulty. You don't want to find out about it when you're already choking. If you're coughing on pills, liquid solids, that's kind of that early identification of, hey, there's possibly a subtle problem going on. So when patients tell me, hey, I feel a little bit off balance, or I notice that occurs, using the same strategies for fall in terms of when is it happening, is there a pattern, is there time, what are you doing when it occurs? Having all of those metrics in hand, so when you go talk to your doctor about it, you can work on identifying what could be the problem, or just working with physical therapy on what kind of interventions or strengthening should I be doing to help improve my balance to not be as off balance. Yeah.
How long is normal?
Yeah, so the question was, how long is a normal dose of medication good for in the patient? That's going to depend on which medicine you're on, which formulation, and different drugs as well. So not necessarily just levodopa, but also dopamine agonists, things like that. In terms of your question, I'm thinking you're probably talking about cinnamon, carbidopa, levodopa. The immediate release one, for some patients initially, can last them the full day. But for some patients, very commonly, we need to dose it 3 times a day. Missing a dose in the early part of the disease, sometimes patients don't notice that they missed a dose, but as the disease progresses, you get into those fluctuations. In terms of that chart that I showed you at the beginning with when symptoms start to come on, when things start to work not as well, at that kind of 5 to 7 year mark is where we start to notice some of that fluctuations start to occur where we get wearing off of the medication. So dose could last some patients as much as an hour, but other patients longer. Okay. And so if that occurs, sometimes dosing more frequently or changing formulations that last longer are going to be the types of things that are helpful. Okay. So home modification and safety measures. So some other things that you can do in terms of a home assessment before getting an occupational therapist on board is some things you can do. So removing tripping hazards. So removing clutter, making sure that rugs are secured so they don't lift up. Tacking them down can help reduce fall risks at home. Installing grab bars in kind of high risk areas. So things like the bathroom, shower, hallways where you may not have that support. So being able to get that extra stability around the house as you're mobilizing. And then ensuring proper lighting. So some patients don't like having night lights on because that can disrupt their sleep. So there can be some motion sensing night lights, things like that. So when your feet step off the bed, it sense that you move, and then that night light kicks on then. These are kind of simple initial steps for home modification. So dizziness is a pretty common symptom that comes up in the adult population. And so there's a wide variety of things that can contribute to dizziness, both Parkinson's related, medication related, and then non-Parkinson's related. Descriptions of dizziness that I hear from patients are, I feel like the room's spinning, or I feel lightheaded. I feel more lightheaded when I stand up. I have a fear of falling. I feel like I'm moving on the inside, but nothing else is moving. All of these are variable descriptions of dizziness, and it's really important that you determine what kind of dizziness you are having. But dizziness can be a sign of cardiac issue. Dizziness can be associated with low blood pressure. Multiple medications that are not Parkinson's medications can also contribute to it. So just being aware of that is really important. Dizziness can also be the sign of some other emerging health problems. So things like hypoglycemia, if your blood sugar is dropping, or if you've got some inner ear problems going on, is that what's occurring? So being in tune to that as well is also important for reducing the fall risk. So here's a patient who notices that he's been falling after he gets dizzy. So when he stands up, he has to get his feet steady before he can take a few steps. And if he doesn't, he's liable to fall. So he hasn't necessarily figured out exactly what it is, but he's got a good description of the symptoms. For him, when we heard that he was having this kind of positional change, we suspected, hey, maybe he's having some drop in blood pressure. We determined he was having orthostatic hypotension, which is where when you stand up, the blood pressure drops because you're not able to get that blood flow from pulling in the feet back up to the brain. This can be common in the adult population. If you're dehydrated, you're not going to have enough fluid in the tank to keep upright. And then they can also happen in Parkinson's disease, where you have that neurogenic dysregulation, where the neurologic control of getting that response is impaired too. So it can be further exacerbated by dehydration in Parkinson's patients. So for this patient, we determined that he was staying hydrated with water, but he was someone who drank a lot of coffee. He noticed he would urinate pretty frequently and felt thirsty pretty often. So we talked about some interventions for him. One of the things that we did was reduce his caffeine intake and talked with his doctor about some of his blood pressure medications that was contributing to some frequent urination. And with those two things, we were able to improve his episodes. So kind of gets back to what I was saying at the beginning, remove those pumpkin spice lattes to prevent fall. Just kidding.
Excuse me.
Yes.
So the decaf, he has.
As a diet, yeah. So the decaf does still have some caffeine in it, but it's definitely lesser of 2 units. So with my patients, I tell them, let's try and reduce that caffeine intake, not completely eliminate it. It's very tough. But keep it to that morning time. Decaf is a good option. Maybe if you are a heavy coffee drinker, maybe find teas that are less caffeinated for you. Trying to work to figure out what helps. In terms of having things like caffeine, Coke, tea, coffee, if you are having any of those, I like to tell my patients if you have 1 cup of coffee, make sure you have 2 cups of water to make up for the water that you're losing from the coffee. And that's going to be in addition to your standard hydration regimen, 32 to 64 ounces. But managing that orthostatic hypotension, consuming more fluids. Salt can help out too, but if you do have some blood pressure issues, hypertension, making sure that you're talking to doctors about that kind of risk-benefit conversation. If you are having that sort of orthostatic hypotension, gradual position changes. So don't stand up too quickly. Slowly change position. Get your feet in place. Sit for a couple of minutes before you get going. Stand for 30 seconds before you get going so that you're making sure that you're acclimated to the blood pressure change that occurs. And then some physical maneuvers to help get yourself ready to start moving. So crossing your legs, tensing your leg muscles, starting to volitionally bring some of that blood flow back from pulling in the legs from those seated and resting positions. And then if that's not enough, things like compression stockings, wearing some of the medical grade compression stockings that come up above the knee or up to the thigh to help compress some of that fluid back up. Okay. And then I want to touch a little bit on cognitive impairment. So trouble thinking. This is something that can occur quite commonly and contribute to a fall risk as well. Things that can contribute to cognitive impairment, polypharmacy, being on multiple medications that having a lot more medicines that maybe affect our neurological function, or anticholinergics are kind of the big ones to look out for. Over-the-counter ones are going to be anything that says PM on it, are going to have some amount of anticholinergic effect. That's what's helping you get to sleep, but also can contribute to some trouble thinking as well. Dual tasking is very difficult in Parkinson's disease, and sometimes trying to do 2 things at once can, especially while walking, can contribute to a fall risk. I'm going to give you some patient examples here about how cognitive difficulties affected their ability to, or their fall risk. So in the first patient, let's say we have a patient, he's sitting in his living room, and then the doorbell rings. And he was someone who suddenly stood up to go answer the doorbell. He was really anxious that he had to get to the door on time because he felt he was a bit slower to do that and didn't want to keep people waiting. When he did that and got up too quickly, he tripped and fell down. So what kind of interventions could we do there? That's not necessarily a medication problem that's going on. That's kind of an activity environment problem. So what we talked about was having his family members give him a 5 to 10 minute text message update that, hey, I'm on my way home. So it wasn't just a doorbell that he's suddenly there. He had a chance to actually get himself ready and over by the door in time for family. Packages with delivery instructions to just leave it at the front door so that he can come get it on his own time, or sending it over to the post office instead, so he didn't have to worry about that. His caregiver could go pick that up. Just a couple of simple things, but there's a certain kind of impulsiveness that sometimes goes along with that cognitive difficulty in Parkinson's disease. Another story I have is a patient where they said he uses the walker, but he just doesn't remember to use it. He's not walking. And I was like, here, let's see how he's using the walker. So we took the walker out to the hallway, and he's holding the walker like this as he's going. Yeah, he's forgetting to use the walker. He's not paying attention. So really identifying where the walking difficulties are coming in and how cognition plays a role can be helpful. And then another story I have is this patient was doing well, but they were telling me there was fall difficulties at home. And then during the exam, he was very focused on his walking and making sure he could do his taps. He could stand up well. He could use his walker, walk down the hall and back for me. And then we got to the end of the visit and we were getting ready to say goodbye. And as we were getting up, he was getting up and saying, "Thank you, doctor. It was really nice talking to you." But as he was getting up, he started to really shuffle a lot more. He got stuck as he was trying to turn to get out the door. I was worried he was almost going to fall over. So we sat him back down and talked about how make sure you're focusing on the task that you're doing. So that's an example where he was having that dysfunctional automatic system starting to act up. So he wasn't actively thinking about those movements. So that was the problem for him. There are some medications that can help out with cognition that you can talk to your doctor about. Some of those medications are borrowed from like the Alzheimer's class of medications. They can help with like cognition and processing speed, a bit of attention. Things like donepezil, Namenda, Aricept, Exelon, those kind of things can sometimes be helpful with some of these kind of symptoms. Yes.
What about the lack of focus?
The lack of focus.
Yeah.
Yeah. That's definitely a problem that comes up when there's cognitive impairment with the lack of focus. Is there any other question with that?
So what can you do about it?
What can you do about it? Yeah. So interestingly, possibly a little bit counterintuitively, but going back to my talk about the speech language pathologists. So some of the strategies that they have some cognitive rehabilitation strategies, cognitive rehab, to help you with identifying times you're losing focus and implementing strategies on how to improve that sort of focus. Yeah, so this is just getting back to me showing you the voluntary versus automatic movements. So really you want to try and increase focus on that non-dopamine dependent pathway. So the pathway where you're actually thinking about how you're moving with an intention. So a lot of that are going to be associated, like I talked about, when you're learning new activities, when you're pushing yourself and thinking about how you're moving. You're working with physical therapy, they're telling you, move like this while doing this at the same time in that controlled environment. That helps train your brain to incorporate a lot more of the voluntary movements so that you're able to help keep yourself upright from falling. Okay. And then there's an important aspect to all of this in just having multidisciplinary approach to care. So the doctors can only do so much. You have multiple healthcare providers that can help you along the way. So you have your neurologist who helps diagnose and manage the Parkinson's disease and helps coordinate your care with allied health professionals and primary care doctor. Your neurologist is not going to be able to manage your chronic medical conditions, but just working together with at least those two doctors is going to be super important to be able to help you take care of medications. But then there's only so much that your doctors are able to do, so getting therapists on your team is also helpful. So like I mentioned, physical therapist, speech therapist, occupational therapist, each of them has a role for different parts of the care of Parkinson's disease. And then monitoring your progress along the way. So as you're working with physical therapy, making sure you're meeting those goals, milestones, working on those exercises at home, making sure that you're keeping up with those speech exercises in between speech therapy visits, because you're not going to be seeing speech therapy all year long. You're going to be touching base with them along the way. Your doctors, your neurologists are going to monitor your Parkinson's disease and see when symptoms are worsening, but you're going to be telling them, hey, I'm experiencing these changes with my symptoms too. Working all together to monitor how you're doing along the way. Making sure you remember that you've got support from your caregivers and family. And so emotional support is definitely very important. It's going to help you with supporting your assistance with your daily activities. They'll enhance your quality of life. They can help with identifying times that you're maybe not noticing the difficulties that you're having. And then you can lean on them to help you with some of those daily activities as well. And then that can help you kind of focus on your independence, things that you want to be doing. And then things like this, community resources, support groups, Parkinson's Association of the Rockies, all of these kind of things help with providing you guys with more information and resources to help talk about these really important topics. Staying really connected socially, helping understand what are other people doing. Or I don't like using the cane, but he's got this really cool walker. Where'd you get that? Or I like those trekking poles. Interacting with one another to understand what all of you are doing and see how you can help your care out too. The shared experiences are so helpful to help you all go through this journey together. Let's remember, like I said, once you've met one patient with Parkinson's, met one patient with Parkinson's. All right. So that's pretty much all I have. So it's important that we prevent these complications in Parkinson's disease. Really requires us to be proactive. And then addressing the speech and swallowing changes and mitigating fall risks, we can improve your quality of life and then prevent those complications that result in morbidity and mortality. Okay. And then I probably ended a bit early. Yeah. Now we have the next hour to chat, right?
I have a question about insurance. Does insurance cover speech therapy, occupational therapy? What limitations are there?
Yeah, so what I tend to notice, each individual insurance is different, but in general, they don't support seeing a speech therapist, occupational physical therapist all the way through. Some insurances will allow you to have just like do a couple of sessions with focusing on speech or a couple of occupational, sometimes not doing both at the same time. Other things with insurance, if you want to do these therapy services, sometimes doing them at home is really convenient, but if you do them at home, insurance may not cover you being able to do it at home as well as away from home. So planning together, maybe this is the year that we're going to work on doing these at home right now because of the status that we're in, but maybe next year when we're doing these therapy services, we're going to be able to get out to the therapist, give us something to go do so that we can get a different perspective on how to do these therapies at home. I wish I knew more about individual insurances, but in general, it tends to be when that insurance year turns over, that's when we can start refilling those prescriptions. And so just being sure to stay in communication with your neurologist, saying, hey, I need a new script for physical therapy, or I need a new script for occupational. In the context of Parkinson's disease, it's an ever progressing disease. So I'm definitely a firm believer in repeating these therapy assessments along the way so that we're identifying these subtle things as they come up. Having just that initial speech therapy visit at the start of our diagnosis is not enough to support us as we go through this.
What resources is there? So they have groups of it or?
Yeah, so the question is, what resources does the university have? And so in terms of resources at the university, we've got a lot of different programs for Parkinson's patients. One of the programs that we have is a multidisciplinary clinic for Parkinson's patients where you can see your movement disorder specialist, and then in an offset cycle, maybe like once a year or once every so often, you can go check in with the multidisciplinary visit where you see one of our APPs, advanced practice practitioners, as well as physical therapy, speech therapy, occupational therapy, kind of all together in the same visit. It's kind of one of those resources we have to kind of incorporate all of this.
So that could be done out of like regular.
Yeah, as like a one-time visit to go do that, kind of get all the recommendations that you need, so then you can bring some of those tactics back to your speech therapist or your physical therapist here, so you can work on some of those methods. I did look at, I did a search on the Parkinson's Vocal Project website to look at kind of the nearest speak out classes to you guys, and I had to expand the search frame for 250 miles to actually capture something close to Durango, so over like towards Pueblo or Colorado Springs or Denver. But like I said, a lot of those programs can be done virtually too. And so that virtual incorporation is definitely helpful for those very frequent visits. And then other resources that the university has, not necessarily a resource, but kind of a research type of approach, is that we're doing a lot of research in Parkinson's disease, and we have many ongoing trials, not just trials for those who have not been on medication, but patients who are already on medicine. Exercise trials, though those are usually a benefit to be kind of close by to do those trials. And then we always have new studies that are popping up. So you can go to, and I think they'll be able to share this with you, but the CU movement .org, I think it is, and underneath that website, there's a research tab, so you can look at that too. Yep.
I take solid, over. 2 pills 3 times a day. What happens is, it's hard to, it's easy to miss the pill. Did I make it up? I take an extra pill, and it's fine. What's it about?
Yeah, so I will try to caution against making specific medical questions and medical recommendations. But the question was, sometimes it can be difficult to remember to take that middle of the day dose. And that's a really common problem that does come up. So some things to get ahead of that are going to be setting an alarm to take the medication. Sometimes keychain, if you go to Walgreens, you can get like little keychain attachments to have like a emergency set of medication just on hand in case you forget it at home. Having like pill boxes that have scheduled times to take the medication. But in terms of individually for you and whether you should catch up on medication or take an extra dose, definitely discuss that with your neurologist, because there can be different risks to taking more of it later, or if you're someone who should just take a little bit extra. It really depends on your entire medical picture. So that's something I can't necessarily comment on. But these are some strategies that we can use to help with that middle of the day dose.
Is it recommended to take the carbidopa? Is there a time span with food?
Yeah, so the question is taking levodopa and food. And so there is an association with the decreased absorption of levodopa. So levodopa is an amino acid analog, and proteins are made of amino acids. So when you're ingesting proteins can get in the way of absorbing the levodopa. Now, when you're first diagnosed, when you're early in the disease, I tell patients don't worry about this, because it doesn't make the absorption 0. It maybe reduces it from 100% absorption to maybe 90%, 100% absorption to 70%, depending on some factors. I only want patients to worry about that when it becomes a problem. The medicine's working and you're tolerating it with food. I don't want to scare patients away from the medicine because they have to take it on an empty stomach and experience the nausea or some stomach upset from being on the medication on an empty tank. But maybe along the way, once we get to maybe that 5-7 year mark, and maybe we're getting into some of that wearing off, or we notice that the afternoon dose just doesn't work as well as the morning dose, maybe that's when we start talking about managing our meals with the medication. So when that comes up, what I like to tell patients is 30 minutes before a meal or 1 hour after finishing a meal is the time you should target to take the medication.
Does heat affect the pills? The levodopa, the heat?
Does heat affect the pills?
Yeah.
Like, does heat affect how well you absorb the pills, or
if I leave in my car and the temperature gets to be 120 degrees, is the pill still good?
I imagine it is still good, but definitely a good question to ask your pharmacist the next time you pick up the medication.
Is this information and presentation on the website?
So this,
For you to look at?
yeah, this presentation will be recorded and they'll be uploading it to the YouTube page of the Parkinson's Associations of the Rockies. And on that website, you can actually look back at prior presentations and videos on a variety of different subjects as well. In terms of the slides specifically, I'm not sure if that's also shared. Jody? Are the slides shared for patients, or is it just the recording?
The recording is shared. We're happy to share the slides. We obviously have permission from the doctors, which we usually do. So if you want the slides, you can ask us.
We typically don't just send them out to everybody because not everybody wants them, but if you want them, we can get them to you.
Good questions.
We can use our that.
What can I tell you about the DAT scan? So the DAT scan, all it tells you is whether or not there is loss of those dopamine neurons, and tells us if the presynaptic dopamine deficit is present. Doesn't tell you whether you have Parkinson's disease or an alternative atypical Parkinson's disease. It just tells you that there's something going on with those neurons. So, and that's what I can tell you about the DAT scan itself. Can be useful if there is question of the diagnosis, but really Parkinson's disease is still a clinical diagnosis, and DAT scans are mostly used as a supportive feature or in alternative disease states looking into a cause of the patient's Parkinsonism. Question over here? Yeah. Over there?
Does certain point your body stops producing dopamine? Is that right with Parkinson's?
So the question was, at a certain point, does your body stop producing dopamine with Parkinson's disease? And what Parkinson's disease is the neurons that produce dopamine slowly die over time. So overall, the amount of dopamine the brain is producing is reduced. In normal aging without Parkinson's disease, the brain actually does make less dopamine over time. So that natural progression is that the brain will make less dopamine. There's just a certain threshold that you cross over before you start to get Parkinson's or Parkinson's along the way. If I let someone continue to age all the way to 120, they might actually look like they have Parkinson's disease just because of that natural loss of dopamine. So your question of will the brain stop producing dopamine? There will still be some of those neurons left over. So there's just going to be a highly reduced amount of dopamine production, but the brain is continuing to make a little bit of dopamine.
So your pills or the amount of antitaking get from medications makes up for it?
Exactly. What I like to talk to patients about is as the brain is making less dopamine over time, it crosses over this threshold where symptoms become bothersome. And then as it continues to decrease, we use medicines to bring ourselves up to where the symptoms are not bothersome. So as it continues to decline, we need more medication to make up that difference along the way.
Does exercise help to increase the dopamine production?
So the question is, does exercise help to increase dopamine production? So we have some research that's going in exercise itself and its impact in Parkinson's disease. What we understand about exercise so far is that exercise helps maintain the health of those dopamine producing neurons. So in a way, it increases the dopamine production by keeping those dopamine producing neurons healthy. And then intrinsically by doing exercise at the time of exercise, there is a flood of neurotransmitters, dopamine, serotonin, epinephrine. All of those things are released with exercise, but it's kind of a two-part question. One is what's the importance of exercise related to the dopamine producing neurons, and then the question of does exercise produce dopamine itself? Which the easy answer is yes, it produces dopamine. But for Parkinson's patients, what we care about is preserving the health of those dopamine producing neurons. So exercise is the only treatment that we have that actually does slow down disease progression. So the rate of loss of those dopamine producing neurons is decreased with exercise. So really beneficial to be exercising.
Is it just aerobic exercise or is it strength training exercise? There's different categories of exercise.
Exactly, which is why we're doing research on specific types of exercise to see which ones are influencing that more than the other. But in terms of what kind of exercise you should be doing, the exercise I talk to patients about is following the American Academy of Neurology guidelines for brain health. In terms of preserving good brain health, they recommend targeting 150 minutes of aerobic exercise a week. So that can either be 5 30-minute sessions or 3 50-minute sessions of aerobic exercise where you're getting your heart rate up, and then mixing in some resistance training with that. Things that I want you to think about though is I don't want you walking out of here and going and doing 150 minutes of exercise today. That's not what you normally do. That's something to work your way towards. Any little bit can help you out. So whether you're doing maybe 5 minutes of aerobic brisk walking, followed by 5 minutes of walking at a regular pace, and just doing that kind of 10-minute routine 6 times in a day will just get you to 30 minutes of aerobic exercise that day. Spreading it out over the day, doing that. It's a nice little starting way to do that. Getting lots of stretching in as well to keep yourself loose. Trying to mix in a little bit of that resistance training as well to the abilities that you're able to do. Okay, it's a good question. We're trying to do more research on it.
Well, I read about a research study that was assessing different types of exercise. So one group did the aerobic exercise and one group did dancing with the tango specifically.
Okay.
And the tango group had maintained and